All right, good morning, everyone. I'm here to present two cases challenging in CLI. The first case is a 74-year-old male who has history of CAD, ischemic cardiomyopathy, hyperlipidemia, hypertension, diabetes, chronic kidney disease, recurrent GI bleed. He presented initially with this wound on his foot, status post first toe amputation. They tried revascularization before, it's mostly below the knee, and they failed. And this is his anatomy on the first procedure. For the sake of time, the SFA popliteal artery are open, the PT-AT are open to the mid-segment, and only the peroneal is feeding the foot. So that was his first procedure. Obviously, I tried to go ipsilateral, tried to cannulate from above, but there was extravasation. There was a piece of calcium. This is a laser here. Mostly this area is heavily calcified. There's a cap that I couldn't cross from above. So the first thing that I do, I stacked from the common plantar artery or slightly higher, put a wire there. Still, I couldn't break the calcium cap here. Yes.
Point over there.
Okay, sorry. So we went here from the common plantar artery slightly above in a retrograde fashion. Still, I couldn't break the cap of calcium here, so I went more distally in the lateral plantar artery under ultrasound guidance, put a wire there, and was able to get into the true lumen there. The next thing I did is here I put a sheath from the common plantar artery, and with the sheath and the introducer, I was able to break the distal cap here and put my wire. Advancing the sheath a little bit more, I was able to come from above after ballooning and introduce the wire into the sheath and pull the sheath progressively and put the wire all the way distally into the lateral plantar artery. So this is after getting the wire into the lateral plantar artery all the way distally and ballooning, and we got this result. And I thought at this point that this is enough for him with this kind of wound that he had. He will get a good local wound care, probably wound vac and hyperbaric oxygen. However, over that period of time, the patient had GI bleed. He was admitted for unstable angina. He underwent another procedure. He was not able to continue his antiplatelet therapy, and obviously he occluded. He underwent a second procedure on the PT again. At that time, we had to put a stent because in the PT, a wire broke in that area. He underwent transmetatarsal amputation, and obviously it was not healing. So we brought him for the third time for a full revascularization. And this is his anatomy. SFAPT, popliteal artery open. ATPT to the mid-segment. And this is at the level of the ankle. Again, in an antegrade approach, I was able to go, and since this was revascularized before, to go into the lateral plantar artery with a microcatheter inject, see what's the anatomy.
Exactly.
The catheter was pulled back to see the medial plantar artery and the lateral plantar artery. A wire was placed into the lateral plantar artery, then verification that I'm in the medial plantar artery. A wire was placed there. We ballooned. This is why I got there. Gave ample of nitroglycerin. Tagging on Dr. Walker talk on the wires. Typically here I use what I call Xi'an black wire that we use in the septal surfing. I was able to surf the transmetatarsal arch, balloon the transmetatarsal arch up to the distal pedal artery here in DP. We were getting decent result, but I felt we need to complete the transmetatarsal arch and revascularize the AT and the DP in order to have a full healing. This area here was heavily calcified. I was not able to go in a retrograde fashion. I knuckled the wire from the AT all the way down to this area. Then again, using a stiff wire, which was a Stadio 20 or a Stadio 30, with the support of a microcatheter that we use in the coronaries. It's called the turnpike spiral that has a wire around it and can cross the calcified lesion. I was able to pierce this area, drive my catheter through up to here, then exchange my wire into a soft wire, push my catheter even further, switch into a roto wire, and use 1.25 burr in this area. Following which we were able to balloon with 2.5 millimeter balloon, the distal plantar artery, the DP, and the transmetatarsal arch. And that was the final result here, was full revascularization of the transmetatarsal arch and below the ankle vessels. That was during intraoperatively, full blood here, and there was 1 month healing of the transmetatarsal amputation in the office of the podiatrist. So the key point, distal access beyond the distal PT, common plantar artery, selective injection with nitroglycerin in the pedal vessels, it will open more avenues for you. Surfing the arch connection with septal wires, and use the penetration wire with the CTO microcatheter, and loop completion was essential for healing in this case. Case number 2, 50-year-old male with extensive history of PAD, status post multiple intervention, left common femoral artery, left iliac stent, left SFA stent, presented with CLI, non-healing ulcer of his left toe, known to have amputation of his first and second toe. A big person, 6'1", 266 pound, BMI 35.1. Not mentioned here that he has also occlusion of the right iliac artery. So we went from the radial artery. This is his anatomy, flush occlusion of the SFA.
Yeah. High-grade common femoral too.
This is his anatomy in the mid SFA popliteal artery. There is a stent here. That's below the knee, only the peroneal artery is open. And there was only the peroneal artery going down to the foot. So we access from above, put in my wire, then using the Schmidt technique, I was able to visualize the distal AT, stick a wire, stick a sheath, and go retrograde. We're able to connect all the wires from above, from below, and then balloon the SFA, popliteal artery, AT. However, no matter what I did, I kept going behind the stent, coming from below, coming from above, using double lumen catheter, parallel wires, stiff wire tried to penetrate. My wires kept going beyond the stent. We ballooned with 5 balloons, 6 balloons, 7 balloons, but this is the result that I was getting, not satisfactory. So I decided to go ahead and put a stent in the subintimal space, and that's the result that I get. Now I had to complete the loop. He has ulcers in his toes, so I went antegrade from the proximal SFA all the way down, balloon the AT, balloon the peroneal artery, all the way down to the loop, balloon the distal DP, the transmetatarsal arch, and close the punctured site by prolonged balloon inflation. From the radial artery, we closed, because he's a big person, we don't want to take a chance with bleeding. We balloon tamponade the access site here, and he was left only with the left radial artery access, and there was no evidence of extravasation. So, and he healed actually his toes. Anatomically difficult patient, consider multiple points of entry. Strategy to cross ISR, laser, crosser, direct puncture, power knuckle, some intimal recanalization. I'm not sure about the long-term patency, but at 3 months, the stent was still open, and full revascularization to the foot is essential. Thank you.